Hi, my name is Molly Zerlip, and I am excited to talk to you today about percutaneous tricuspid annuloplasty. I'd like to thank the organizers of this symposium for letting me speak today. These are my disclosures. All right, so tricuspid regurgitation is becoming more and more of a problem. What was once a valve that we really didn't think about, we now think a lot about, and it causes a lot of morbidity and mortality. So really there are two main categories of tricuspid regurgitation, much like mitral regurgitation. We have primary and secondary, with secondary being the most common cause of tricuspid regurgitation. And out of secondary or functional tricuspid regurgitation, annular dilatation is usually the predominant etiology of functional tricuspid regurgitation, and most often from atrial fibrillation. So the primary mechanism of functional tricuspid regurg is this annular dilatation in the anterior posterior plane. And so there have been devices that have been developed specifically to address anterior posterior plane. And why is this important? Well, we know that functional tricuspid regurgitation increases mortality, and it really doesn't matter the severity of TR. So especially at moderate and severe TR, there's an increase in mortality, and this is independent of pulmonary pressures, LVEF, IV size, or even RV size and function. So how do we treat functional TR? Well, in the past, the gold standard has always been surgical tricuspid repair. But the problem with this is that patients are often high risk for surgical tricuspid repair, mainly because they have right heart failure and can have liver involvement and hepatic failure. So what are the outcomes of isolated tricuspid valve surgery? Well, again, in the past, the 30-day mortality has ranged anywhere between 8% and 16%, though more recently at our institution, our 30-day mortality for isolated tricuspid surgery was 3.2% with a 5-year survival of 74%. So even though this is better than that 8 or 9% mortality, it's still pretty high when you're talking about surgical mortality. So because of this, we need other mechanisms or treatment options to be able to treat this tricuspid problem. So when we talk about percutaneous tricuspid repair, we want to focus on this annular dilatation, and specifically we want to mimic surgery. But the challenges to this are, one, that the RV is very thin-walled. It's not like the LV, which is thick-walled. There is a small angle between the IVC and the tricuspid annulus, which can make delivering a device quite challenging. And much like mitral regurgitation, where the mitral annulus sits close to the left circumflex, the tricuspid annulus sits close to the right coronary artery. And you have to be careful when you do types of annular devices that you don't impinge on this right coronary artery, because if you do, you can get ischemia and have RV failure. And the last thing that makes it very challenging for doing a percutaneous tricuspid repair is visualizing the tricuspid leaflets. So this can be very, very difficult. We obviously use TEE and 3D TEE, but we also need 3D ICE, and when that becomes widely available, that will help a lot, because these leaflets are often very difficult to see, and it's very, very dependent upon your imager as to whether or not you can get good tricuspid pictures. If you can't get good tricuspid pictures, then you can't do a percutaneous device. So what about percutaneous tricuspid annuloplasty itself? Well, currently in the US, there are two types that are under study right now, direct and indirect approaches. There's the Cardioband, which is by Edwards, and Tricench, which is Fortec. So what is this Cardioband system? Well, it's the first CE marked approved transcatheter device. It's a dedicated technology to actually treat the annular reduction. It's a device that goes around the annulus. It was developed first for mitral repair or mitral annuloplasty, and the device is similar. It shares the same components and as well as the procedure steps. So this is a femoral vein access on the right side, and for us, we did it under both 3D TEE as well as 3D ICE, and this is to help against shadowing. And basically, they are anchors that go into the annulus, and it mimics that of a surgical ring, and then you can cinch it down under TEE, and this will you can decrease the amount of tricuspid regurgitation by how much you cinch, and that's the device works. So here we're doing an early feasibility study in the U.S. It's a single-arm, multi-center prospective study of 7 U.S. sites, and it's to evaluate the performance of the device. Safety is defined as a composite endpoint of major adverse events at 30 days, as well as performance successes like device, procedural, and clinical success. And then secondary endpoints are looking at echocardiographic data like TR grade, EROA, and regurgitant volume, as well as New York Heart Association class, the 6-meter walk test, the KCCQ, and this is followed at discharge 1 month, 6 month, 1 year, and then annually for 5 post-implant. So far the interim data has shown that this is technically successful. It's been successful 93% of the time. The annular reduction has been reduced by about 14%, which is pretty good. And then TR is reduced by 40%, and it's maintained this at 30 days. Conclusions from this study is that the initial U.S. experience is acceptable and safe. There's significant annular reduction in TR reduction at 30 days, and it's clinically significant improvement in functional status and quality of life. This is what the device looks like. So as you can see, there's a wire down the right coronary, and then at the end you can see that the right coronary is not affected, and it kind of looks like a surgical band. This is what it looks like on echo. To the left image you have severe TR, and then the right you don't have any TR. It's a pretty good result. The second device is a Fortec tri-cinch coil system. This is a coil implant that sits epicardially with a steerable delivery system that you deploy a nitinol stent in the IVC. Again, it's a single anchor implant that's connected to a stent that you deploy in the IVC, and then you cinch it down also under TE guidance to decrease the amount of tricuspid regurgitation. This is also under EFS trial, and as you can see, this is what it looks like. To the left is putting in the epicardial implant, and then to the right you're deploying the stent in the IVC and cinching down. Here is the initial TR followed by the final result. So in conclusion, percutaneous tricuspid annuloplasty mimics surgical repair. This targets annular reduction to reduce TR, and the EF studies are ongoing, showing initial safety and efficacy of the two devices. Thank you.